One of the most common disease yet under-recognized neurological disease encountered in primary care, early identification and timely intervention is essential to optimizing the patient outcomes. It's our pleasure today to welcome Dr. Ashraf Amir, Consultant Family Medicine and Chief Medical Officer at IMC Group Jeddah. He's the Assistant Professor of Medicine at Al Qura University and the Vice President of the Saudi Society for Family and Community Medicine, and he's the President of the Saudi Family Medicine Club. Now, Dr. Ashraf will lead us through discovering the migraine patient journey. Dr. Ashraf, the floor is yours.
Thank you, Dr. Salma. Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala Sayyidina Muhammadin wa ala alihi wa sahbihi ajma'in. Dear colleagues, ladies and gentlemen, respected speakers, honored guests, Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of the Saudi Society for Family and Community Medicine, it's my pleasure to welcome you all to this special event, which is accredited scientific meeting under the title of Optimizing Migraine Management in Primary Care. And I just want to deliver a very strong message now that migraine is not only a headache. It's just beyond what we expect. It's not a disease with certain symptoms, but it's a disease with significant impact on the quality of life, on the productivity of people, emotional well-being, and family dynamic also get affected. And all of us as primary care physicians, we have been positioned in a proper locations, to address this kind of suffer of patients and to have the early recognitions and to have the accurate diagnosis and, of course, the appropriate management. So today, ladies and gentlemen, tonight's program will bring together a valuable expertise and a practical insight, which will aim to enhance our competency to diagnose and treat migraine. And we are privileged to have with us distinguished speakers who will share with us their knowledge and their expertise in the field of migraine. So I would like also to extend our thanks to all of you to attend our sessions and for all the participants who join us. And I would like also to address our grateful thanks to the organizer, ملتقى الخبرات لتنظيم المعارض والمؤتمرات, and the sponsor, AbbVie, on top of them, Dr. Salma. So thank you, Dr. Salma, for supporting this continuous medical educations and advancing our patient care. So we hope our sessions will be quite interesting for everyone, interactive, and please feel free to prepare your questions, make the sessions more interactive and more fruitful for all of us. So thank you once again for being here, and I wish you all an enjoyable and productive evening. So our agenda today, we are going to have 3 presentations. The first presentation will be about the burden of the disease and the burden of migraine and the journey of patient, which is very important for us to understand it and to have a look on it. And this will be followed by a presentation for Dr. Badr bin Hamd, and Dr. Shapiro will be the last one to deliver the update in the management of migraine. So without any further ado, I would like to share my screen and I will start my presentation, which I hope that it will be quite interesting for you because it will highlight one of the most important parts that we have to address as a physician for patients who suffer the disease and have a disturbed journey throughout the spectrum of our healthcare system. So in the coming few minutes, I'm going to talk about discovering the migraine journey. So it's very important for us to know how we perceive the migraine burden on patients. And for this, I brought for you a scenario of different 3 patients who have been describing migraine as a severe pain. So it was described by one of the patients like ice pick to an axe that hit the head and splitting the head into 2 parts. So this is how severe is the pain that is causing this kind of severity by this kind of explanations. The other patients, she said, it's almost like a hammer hitting my head. And the result of this, she was totally disabled and she was not functioning appropriately. The other patient said it is not only a headache, but also it's incapacitating. So she cannot perform, she cannot go to work, she cannot do her daily activities and responsibility, and she just want to be in the dark room lying down. So this is how the patients with migraine describe the severity of the pain. So let's go a little bit to understand how big is the problem across the globe. So it is quite prevalent, in fact, and it has been counted to be the sixth most common disease in the world. And it's very common in the primary care practice as well, as we can encounter migraine as part of headache. So the prevalence across the globe, as we can see, is almost 14 to 15%. And unfortunately, almost 1 billion people are affected by migraine. But very important hint for us to diagnose migraine. So it is to know which gender is more liable to have the migraine. So it is among the women in certain age, they are more prone to have migraine. So let's go through the features of migraine one by one. So it's a chronic disease. And we know why it is a disease because it has symptoms, it has complications, it is impaired the quality of life of patients, and it has also a burden on our healthcare system in terms of financials or even less productivity. So it is a neurological symptoms, and usually the patient comes with symptoms most likely to be pain, nausea, sensitivity to light and sound. So there is a photophobia, and there is difficult. There is annoyed. I know the patient get annoyed by different sound. So it's a major global health issues, as we said. More than 1 billion people are affected globally, and as we said, the women are more affected. So 1 in 5 women are patients with migraine. So it is more threefold in women when they are compared to men. So men are less affected. So it's a substantially impact the life because it has some impact on the social life at work, at home, and it disturbs the work environment with less productivity, and it impaired the family dynamic as well because of the disability. Not only this, but the pain, which is throbbing type of pain. And this is a very specific feature. So the patient comes with say that I have a throbbing pain in part of my head with a nausea and vomiting, and usually started around the eye and it goes to the consign place. So it's a very common disease, as we said, is the third commonest disease in the world, and it, in some studies is almost the sixth high prevalent disease in the globe. So it's a moderate or severe. So 90% of patients with migraine, they have a moderate or severe. So it's not a mild pain, it's a moderate to severe. And as we said, it reduces the ability to function. 75% of those people who have migraine, they have this dysfunctionality. And it requires also the bed rest for a long period of time. So they spend 1/3 of their time of during their attack at bed. So let's go a little bit and shift the gear to find out how is the migraine is prevalent in the Kingdom of Saudi Arabia. So this is one of the study which showed that 25% is the prevalence of migraine in Saudi Arabia. It's about 12% of the migrainists they seek medical advice. So still we have a lot of majority of our patients with migraine, they try to have their own self remedies or they don't come to the healthcare. So that's why our role here to have early diagnosis, identify those patients with migraine and treat them as early as possible to improve the quality of their life. 52% they report depression. So migraine is not only a neurological disorder, but also it has consequences on the mental disorder in terms of depressions and anxiety. So let's identify exactly what is the impact of migraine on the life. And this is a classical feature of a patient who is a lady between the age 18 to 59 years of age, of the childbearing age. And as we said, they always express the pain and the nausea and the photophobia. And usually it is about 20% they don't seek professional care, as we said. and it's more likely to be in women, threefold in comparison to male. So when we look into the impact of the migraine on the mental health, so 7% of them, they have my anxiety, 9 depressions, and anxiety and depression together, they're about 21% in this kind of study, which can include more than 15,000 patients with migraine. So mental disorder is quite prevalent in migraine, and about 43% of those migraine, they have anxiety, they have moderate and severe disability, and 52 who have depression, they have 52% moderate severe disability. So there is a disability along with the mental disorder as on top of the migraine. So this is, again, this is the burden on the work and the workers. 70% of them, they believe the migraine affected their profession, so they cannot be functioning, and almost about 5 days are lost in the working because of the severity of the pain, and 13% they report reducing number of hours work, so there is less productivity, and 29 agree that they will be more successful if they don't have migraine, and this is a fact which has been shared by majority of the migrainous people. So how about the family life, which is usually get disturbed and disrupted? So about 50+% of the patient, they have reduced participation in enjoyment activities of the family. About 30%, they have impact on their relationship with the spouse, and about 33%, they have impact on their personal financials and income because of the migraine. So the impact of the chronic migraine now, because we talk about episodic migraine, but now the chronic migraine has also consequences, which is not only on the financial security, but also its impact the relationship, and even the parents. They feel that they could have been better parents if they don't have migraine, and the potential impact on the family and caregiver as well. 42% of the caregiver, they are unable to have friend visits. 11% of the children or parents, they have a moderate to severe anxiety, and so forth. So the impact of migraine on the healthcare system. So this is one of the very important study which included more than 9,000 patients. They found that the current medical consultation at healthcare professionals is only 29%, and those who have been diagnosed accurately for migraine were 20%, and the minimal appropriate pharmacological treatment was only 12%, and the successful diagnosis and the treatment barrier was 8%. So it is very important here to find out that 14% they receive minimal acute pharmacological treatment, and 17% they have received the appropriate preventive. So we are misdiagnosing patients with migraine, and if we are treating them, they are undertreated, and most of the time they are underdiagnosed. So this is the chronic migraine, which is often undiagnosed and undertreated. 40% of the consultations for the HCP for headache, and from those, 24% they receive accurate diagnosis, and out of them, 44% they receive the preventive treatment. So we are lagging behind the appropriate timing for appropriate diagnosis and the treatment for the migraine and even the prevention of the migraine. So the diagnosis of migraine, usually the time for correct diagnosis and misdiagnosis, this is the time by quarter. So 12.4% of the patient who's misdiagnosed, they are diagnosed after 1 quarter, but see after 8 quarters, which is almost 2 years, 29% they receive the proper diagnosis after suffering for a long time. So there is a missed opportunity, in fact. Why? Because this is the patient journey. Usually the patient start with the onset of migraine, so the patient having certain episode of migraine per month, he will try to self-manage by the non-steroidal anti-inflammatory and over-the-counter medications. And then when it's failed, he will go to the primary care physician after almost 4 years, and the symptoms will not get relieved. So he has suboptimal treatment or sometimes misdiagnosed. So he'll go for another primary care physicians. Multiple visits will take place, which will take another couple of years. And because of the inconstant efficiency of the medications, he will be visiting the ER multiple times. And then finally, he will be able to reach for the neurologist or the specialist or the headache clinic, where he will give him the prescriptions of the preventive medications, and the journey will continue like this. So it's a very long, disturbed, disrupted journey, which full of agony and pain and suffer. So this is the patient consulting migraine are mostly primary care. So this is in the study, which include almost 21,000 patients, almost 70% of them, 70% of them, they have been visiting the primary care physician, 28 the neurologist, and the headache specialist 15%. So majority of patients with migraine, they seek the primary care. So that's why we have been positioned in a very crucial and critical locations in the healthcare system to accommodate and those patients who comes with us with certain symptoms, to diagnose them appropriately and to manage them accordingly. So we are, as a primary care physicians, we demonstrate the easy accessibility. So we are available most of the time to receive patients with migraine. We look into the patient in a holistic approach. So migraine is not a headache, it's also combined with depression and anxiety and some kind of social impact. And we are cost effective. So the patients, he comes to the primary care, not only for migraine, but with multiple comorbidities. So migraine will be taken care of along with the multiple presentations, and we maintain a continuity of care with patient. So we live with the patient for a long, we build a long-term relationship with patient that continue lifelong. So this is the competency of us as a primary care physician. So caring and compassionate should be demonstrated for patients with migraine, because they deserve this kind of compassionate, integrated care. We have the soft skill of communication, so we can communicate with patient and build the good doctor-patient relationship. We have the clinical competency to diagnose according to criteria and identify the patient with acute episodic migraine and the chronic migraine, and then treat them according to continuity of care. As you have seen, the migraine journey is a long journey that lasts many, many years of the life and maybe the life long. So with this, we can maintain it. The coordinating of the care, so we can coordinate the patients between primary care and secondary care appropriately without any disturbance. And then we also, the cost effectiveness, so we don't cost the patient much. We can manage patients in total, and then we do the counseling for those patients. So my final comment is, so behind every migraine patient is a person hoping for a relief and a better quality of life. A confident primary care physician can make all the difference. So this is a call for action to demonstrate our competency and to manage the patients with a full confidence, especially in the presence of smart molecules that can give us the leverage of having a medication that is quite efficacious, safe, and acceptable to the patient, and can improve the quality of life of patients to be more appealing for the patient, to be more productive and socially active. So with this, ladies and gentlemen, I would like to thank you. And now we'll move to the second topic. Stop sharing. So now we'll move to the second topic, which will be highlighted by our next speaker, Dr. Badr bin Hamd. Dr. Badr bin Hamd is a consultant in family medicine and the chairman of the family medicine department at IMC in Jeddah. And he recognized for his leadership in family medicine services, physician trainings, and healthcare quality improvement. Dr. Badr bin Hamd has contributed significantly to the strengthening primary care practice and enhancing multidisciplinary approach to chronic disease management and patient care in the region. He has been contributing widely to our scientific activities, which is under the umbrella of the Saudi Society for Family Medicine. So I will just leave the floor for him to tell us a little bit more about optimizing migraine care. So thank you, Dr. Badr, for accepting the invitation. I will leave the virtual floor for you. Thank you so much.
Hey, thank you so much, Dr. Ashraf, for introduction, and thank you for the organizing committee. Sorry for my voice. I have a little bit of a respiratory infection. So I hope, inshallah, my presentation will be fruitful and practical بإذن Azza wa Jal. So let me start with this, the content of my presentation today. Sorry. Sorry for that, yes. So we'll talk about the migraine pathophysiology, migraine diagnosis and screening. Then we will move to discuss the evaluation of migraine treatment goal, and we will talk a little bit and discuss about the new modality in acute and chronic or preventive management in migraine. So the learning objective for today is to be familiar with migraine pathophysiology, know how to diagnose and screen for migraine in a busy primary care center, describe the evolution in migraine treatment goal, and incorporate new modalities in the acute and preventive management of migraine. So as we can see here, we are comparing here or seeing the previous vascular theory or the previous all theory of migraine, which is only vascular, talking about the vasodilatation, stretching, and the sensitization of pain receptor. And now we're moving on to the right side, as we can see, to trigeminal nerve activation, which lead to the CGRP release, and this will lead to more pain signaling to the thalamus and cortex. And of course, it is a repetitive cycle. That's why the pain is reoccurred from time to time. So let me deep dive a little bit in the pathophysiology. As we can see here, this slide summarizes the pathophysiology of migraine through the trigeminal-vascular system, which is the major pathway involving in migraine generation and propagation. So what is the trigeminal-vascular system? Consists, as we can see here, with the trigeminal, from the trigeminal nerve fiber, meningeal and dural blood vessels, trigeminal ganglion, trigeminal cervical complex, and higher center thalamus and cortex. So in migraine, this system become abnormally activated and sensitized. So on the left side, we can see the small ending of trigeminal nerve is activated. Then after that, the ganglion, trigeminal ganglion will be activated. And then after that, the trigeminal cervical complex will send more and more signal to the thalamus and cortex. So the key message here is that the trigeminal vascular system is the primary pathway responsible for migraine pain transmission. So migraine pain is not simply a vascular problem. It is a neurovascular disorder involving in nerve vessels and brain processing the pathway. So in the middle, as we can see here, is not only the signals passing through the trigeminal system, but there is release of some important substance like CGRP, glutamate substance via so on, which eventually will lead to more and more sensitization or central sensitization, leading to the symptoms that is the well-known symptoms regarding the pain and the cortical symptoms. So the patient will have the severe throbbing pain, unilateral, sometimes worsening with movement. And also the cortical stimulation, as we can see here, is responsible mainly about the photophobia, phonophobia, dizziness, and allodynia, and other cortical symptoms. So this is explained more and more in this slide. So as we can see here, first of all, the patient will have a stimuli. Whatever the stimuli, it could be stress, it could be hormonal fluctuation, it could be sleep deprivation, fasting, certain foods will will cause some stimulation to the peripheral trigeminal nerve, which lead to stimulation of the ganglion. And we call this the peripheral or first order neuron. And the importance here is once we block this sensitization, so we will prevent the release of, we will prevent the sensitization of the central nervous system, and then after that, we'll prevent the progression of the migraine pain. So in the left side, as we can see here, we call this the peripheral sensitization, which is responsible about some of the clinical symptoms like throbbing pain and increased headache intensity with cough and sneezing and pinding. On the left side, on the right side, with the central sensitization, the patient mostly will complain from what we call allodynia. That means the sensitivity will be more and more from some stimulus which shouldn't cause some pain. And the pain, some like, for example, brushing the hair. So the patient will say, even I have pain while I'm brushing my hair. And also the patient will have what we call hyperalgesia, that means exaggerated response to painful stimuli. So all of this happened after the release of CGRP, which activate the central nervous system. So the question here, why this matter clinically? This concept explains the treatment timing, the importance of early treatment to block the central sensitization. So moving to talk about the neurotransmitter and neuropeptide, as we can see here, which is one of the main factors or the main role responsible in migraine attacks or migraine pain. So as we can see here, we have more than one neurotransmitter like CGRP, glutamate, nitric oxide, serotonin, and so on. So I'm not going to explain all of this in detail, but as we can see here, we have almost 6 main actions like vasodilatation, neurogenic inflammation, nociceptive inflammation or irritation, trigeminal sensor activation, and so on. And each one of these mechanisms is triggered by certain substance. As we can see here, the CGRP in the orange color, as we can see here, is mostly involved in all of these 6 mechanisms. So that's why it's very important to tackle all of these mechanisms by different medications. But the most important medication, as we can see, those medications which really affect or work mainly on the CGRP, which involve in most of these pathways. Moving to the next slide. So CGRP, which is calcitonin gene-related peptide, is a neuropeptide produced in central and peripheral neuron that is thought to play a role in migraine. It's the CGRP blood level increase during migraine and in the infusion trigger migraine-like attack in patient with migraine. And finally, CGRP level normalized with relief of headache after acute treatment with triptan. So the key diagnosis here, whenever we want to diagnose migraine, we need to use some criteria or some evidence about the diagnosis. So we have the criteria, the gold criteria to diagnose migraine, and we can use some validated screening tools. So the question here always we ask ourselves in primary care, what is the barrier or issues in dealing with migraine? So I believe from practice, we have 2 main problems. Number 1 is under or over diagnosis. Number 2 is suboptimal treatment. Again, as Dr. Ashraf mentioned in his presentations, where we are talking about a migraine with disease with high prevalence worldwide, and we're talking about 25% in Saudi Arabia are affected by migraine. So the problem of migraine and why we're talking and discussing migraine today is that migraine, despite having a high prevalence in young adults, still the frequency is high in underdiagnosing and under treatment. And there are many factors. One of the factors, I believe, is the physician himself by underdiagnosing or sometimes undertreating the patient. So whenever we want to diagnose migraine, simply we need to have like 4 pillars. So number 1, at least 5 or more attacks in lifetime. If left untreated or unsuccessfully treated, headache attack lasting 4 to 72 hours, and at least 2 out of 4 features like unilateral location, pulsating or throbbing quality, moderate or severe intensity, aggravated by or causing avoidance of physical activity. All of this can lead to the diagnosis of migraine. And finally, at least one of the following feature, nausea or vomiting, photophobia or phonophobia. So as we know that we have 4 stages for migraine. the prodrome, aura, and headache, and then after that post-drome. So each one has specific symptoms, and it's very important to tackle and to ask about these symptoms to our patient. It takes little time, but really is so informative, and it leads to or give you a hint about the diagnosis. So what about the background? Quickly, I'll not spend time in this slide, but the background development of this screening tool. So why was a screening needed? As we know, migraine is affecting more than 12% of the population, yet the frequency of underdiagnosed or underdiagnosed in primary care is high. Up to 50% of migraine have never received a formal diagnosis. In a busy primary care setting, lack time for full time or enough time to go through the full diagnostic criteria. So they developed, it was in 2003, a very simple tool for migraine diagnosis. The setting was in 11 primary care practice, more than 500 patients. They started with 9 items, and the diagnosis confirmed by headache specialist using the criteria. So very simply, you can apply a simple 3 question in your practice, asking the patient about photophobia, asking a patient about the impairment in his physical activity and work, and finally asking the patient about nausea. So you can just remember the word PIN, so you will not forget it. So whenever the patient answered 2 out of 3, so there is a chance of 75% to have migraine. If the patient is having the 3 symptoms, or so the patient almost more than 90% is having migraine. So, and also don't forget the red flags, which is, you can just summarize it in what we call SNOOP. So systemic signs and symptoms like fever and weight loss, some other neurological symptoms, confusion, impaired alertness, sudden onset with severe pain, older age, progressive headache, or change in the pattern. The patient is having a positional, like the headache is aggravated by different position, or if there is papillary edema, or precipitated by Valsalva maneuver. All of these considered as a red flag, and we shouldn't wait for this patient, and the patient should be seen immediately by a specialist. So always I like to present this slide. So quickly, as a family physician, how to approach patient with headache. Always don't forget to ask a deep, thorough history to your patient, as starting from the chief complaint down to the family history, as we can see on the left side. And please don't forget an important question, as we can see here on the left side, asking about psychological screening for depression, anxiety, drug, and some supplement. And as we know, some drugs and supplements can aggravate migraine, and also sleeping pattern and quality, exercise, the frequency, type, and intensity, and the association between exercise and headache. Diet, very important, because some diet really could be the only cause or aggravation for migraine. And finally, ICE and E, which is idea, concern, and expectation and of the patient, and the effect of this problem or the migraine attack of the patient, quality of life, work, and family. So the question here, or the point here, please don't forget examination, even if you know that nothing to be examined. I believe always this is a power of doctor touch and patient, and this is part of doctor-patient relationship. And of course, it should be directed by the history. And sometimes, at least, you need to do a general examination for the patient just to have more doctor-patient relationship. And this has a great impact on the management plan. So the question here, do we need to do any investigation? So sometimes, yes, based on history and examination, to rule out or to rule in other causes of headache. So moving to one of the important practical tools that help us as physicians and help our patient to track their migraine, and we call it turning patient history into data. So whatever history patient is giving you about migraine diary, so it's better to be written in manually or through an application, very nice and practical application called My Migraine. So it's very practical, and it is in Arabic and in English. The patient easily can download it, and you can teach your patient how to use it, and you can benefit as physician and your patient from this by having all the details about the migraine pain and migraine attacks on daily basis. So here you can record the attack by date and time and duration, and you can record the pain intensity and even the location. It's really amazing. I tried it with some patients. It's very useful, and I believe it's one of the great tools that can be used in the clinic. You can even record the symptoms and triggering factors, and even you can generate some reports. So the question here, as a family physician, as a family doctor, can we manage migraine, acute and chronic, beyond paracetamol and non-steroidal, or should we refer to neurologist? So I believe the answer is yes, we can. We are capable and we have the authority to do that. And I believe in most centers, whether it's a primary or tertiary centers, we start to have this medication with awareness become more and more. So I believe we should start treating patient with migraine beyond just giving the patient paracetamol or non-steroidal. So how to manage migraine? I believe we should think about the management from two ways. So from acute treatment and preventive treatment. So when should we go with acute? When should we go with preventive treatment? We'll see in the coming slide. So acute medication, or acute treatment of migraine can be divided to pharmacological and non-pharmacological. If we want to talk quickly about the non-pharmacological treatment, usually we ask our patient to have a rest in dark, quiet room, cold or warm compression, adequate hydration, small amount of caffeine, biofeedback and relaxation technique, cupping therapy. All of these could help your patient as non-pharmacological treatment. What about the medication? So you can start with some simple medication like paracetamol, sometimes non-steroidal if there is no contraindication. Triptan is sometimes considered with some patients. We'll talk more about triptan in the coming slides. Gepant becoming a new molecule that, like rimegepant or obrigepant, can be used now as an acute treatment for migraine attacks, and sometimes you can use antibiotic. Ergothrovative is not widely used, dietine as well. Corticosteroid in very, very few cases, and this is not, this is beyond the scope of family medicine. Usually we refer the case to pain clinic or neurology. So focusing today about CGRP molecule, which can be used for acute and preventive migraine. So why CGRP? CGRP, as we can see here, very simple figure that illustrate and show the CGRP molecule, as we can see here, blocking the CGRP receptor in smooth muscle and in postsynaptic trigeminal nerve. So it will block the effect of CGRP, which is one of the neuropeptide molecule that aggravate or that lead to the migraine attack. On the other hand, triptan, which can cause some vasoconstriction, it works on serotonin receptor present in the presynaptic synaptic trigeminal nerve and in smooth muscle. So this is the simple way on showing the mechanism of CGRP. So when should we go for preventive treatment? So usually it's a discussion between us and our patient, and it depends on the number of attack, the number and frequency of attack, the failure or overuse of acute medication, side effect or contraindication to acute medication, and as we can see here, the number of headache per month. So usually between 3 and 4 headaches per month, and between the severe or mild, moderate to severe disability. So at that time, you can consider or you can offer your patient to start on preventive treatment. So what are the available preventive treatment? As we can see here, we have the old one like propranolol, anti-epileptic like topiramate is not widely used now. Amitriptyline is, from my practice, it's still working, and it's one of the amazing medication. CGRP antagonist, antagonist monoclonal antibody as injectable form, and CGRP and antagonist as oral form like rimegepant and atogepant. Botox also has some benefit with some patients. So this should be discussed with your patient who does not want to take any medication or who fails some oral medication, especially in chronic migraine. So it could be done by a trained family physician who are interested in injection, or you can refer to either neurology or pain management clinic. I like this slide because it summarizes everything. So on the left side, as we can see, if the patient have less than 4 migraine per day, per month. So this is acute episodic migraine between 4 and 5 days. So it's becoming more and more frequent episodic migraine. If more than 15 migraine day per month, so it's becoming more chronic. And here we can see the acute management for the episodic pain, and then after that we can move to the preventive treatment as we discussed, which cover most of the episodic migraine and the chronic migraine, and some medication that works specifically for the chronic migraine, like Botox and atogepant, and of course most of the injectable treatment cover both the episodic and chronic migraine. And it's available now in most of the centers, and really it's effective, and we can combine some of these medication together. Here we can talk about the effective treatment for migraine attacks and triptan response. So to say that effective an effective treatment for migraine attacks, so the patient should reach a pain-free within 2 hours from intake of the drug and maintaining for 24 hours, and well-being status as defined by the following: improvement of headache from severe to moderate or to mild or absence or minimal disturbance due to migraine-related pain, or no meaningful drug-related adverse event. So effective attack treatment, if the patient received triptan and he has effective attacks 3 out of 4, this is considered as a responder. If less than that, the patient considered as non-responder or resistant or refractory, as we will see in the next slide. So triptan non-responders, that means failure of single triptan resistant, failure of at least 2 different triptan refractory, failure to at least 3 different triptan, and finally triptan ineligibility, that means there is some contraindication to receive triptan. And this slide, very nice and simple, and summarize the whole effect of triptan. So usually you need at least 3 response, okay, with triptan, just to say the patient is responding to triptan. If less than 3, the patient is considered non-responder. So medication overuse headache. So that means individual with a pre-existing headache who, in association with medication overuse, develop a new type of headache or significant worsening of their pre-existing headache, which meet the ICD-10 criteria. So headache occur on more than 15 days per month in individuals with pre-existing headache disorder. Regular overuse for more than 3 months of one or more treatment that can be taken for acute or symptomatic treatment, not better accounted for by another diagnostic criteria. So the clinical importance of medication overuse headache, that over half of people with chronic migraine have medication overuse, and many individuals do not improve after drug withdrawal. Also, individuals meet criteria for chronic migraine and medication overuse headache should be given both diagnosis. So it's one of the main problems. We have many patients that are using mainly on daily basis painkillers just to relieve a simple pain. So this one, I believe this is one of the main problems in our clinic nowadays. So the new acute treatment option, as we can see here, gepant are, as we can see, anti-CGRP receptor antagonists. Gepant include the rimegepant and obrigepant. Mainly, it's available now in our clinic. Unlike triptan, there is no vasoconstriction. Is appropriate treatment for option for those with triptan, considered as triptan non-responder, and there is no evidence of vasoconstriction, as we said. So let us talk about obrigepant, one of the main molecule that is used in acute migraine. It inhibits the binding of natural CGRP molecule, and thereby preventing the downstream effect, including vasodilatation, and has not been shown to lead to any vasoconstriction. So once it inhibits the CGRP from attaching to the CGRP receptor, that means it will inhibit the central sensitization, and it will inhibit the progression of the pain. So obrigepant phase 3 clinical trial, we have 3 main trials in the different phases of headache. So we'll talk about this trial. So the first visit is a screening visit, and then after that it followed by a randomizing phase, which it was in visit 2. Then after that, the patient start to receive the medication. And after that, as we can see here in the orange bar, which show the timeline after taking the first dose, and the researcher here, as we can see, evaluate the outcome in 30 minutes, and after that 60, 90 minutes, 2 hours, 3 hours, up to 48 hours. These are the standard migraine trial endpoint. So the primary efficacy period, the most important assessment here in acute migraine trial, is usually 2 hours after the dosing. And the main evaluation here is the evaluation of pain freedom and pain relief and absence of most of the symptoms like photophobia and phonophobia after 2 hours from taking the first dose. So the beauty of this study is whenever the patient is need an optional second dose, he can take the second dose. So this key can be given if the patient had inadequate response or headache recurrence, and they should take the second dose within 2 to 48 hours. So what we mean by an inadequate response? So if they continue to have moderate headache or severe headache, or they initially improve, then after that, they have the second headache. So what we mean by the rescue medication, as we can see here, so rescue medication could be non-steroidal or triptan, acetaminophen, or antiemetic medication, and there is some restriction from taking this medication. So if the second study dose was taken, rescue medication could not be taken until 2 hours later. And if the rescue medication was taken, a second study dose was not allowed. Then after that, as we can see here in visit 3, which is 2 to 7 days after the initial dose, so an additional medication dose is given just to assist the absorption and the metabolism. And in visit 4, which was mainly about the follow-up, and the purpose of the visit 4 was to see the safety and adverse event and overall study completion. And as we can see here, the primary efficacy, the pain freedom at 2 hours was more with the first group with obrigipad in comparison to placebo, and the absence of most of the symptoms at 2 hours post, those were more with the obrigipad in comparison to placebo. And in the second endpoint, which was about the sustained freedom of the pain from 2 to 24 hours, again, the obrigipad show a high percentage of improvement of the pain in comparison to placebo. So the side effect was comparable between placebo and obrigipad. So, and most of the patients have a good tolerability for the medication. And again, I like the slide because it showed the pain freedom at 2 hours after optional second dose of the treatment. And they have compared 3 groups, those who start initially placebo, then after that, again, they have second dose of placebo, those who start the first dose with obrigipad and the second dose with placebo, and those with start with obrigipad and they continue the second dose with obrigipad. So the relief was here, as we can see here, almost 15% the pain freedom was with placebo, and those who start with obrigipad and placebo was almost 19% relief after 2 hours, and those who start obrigipad and have the second dose of obrigipad, they have pain freedom by 34%. Moving to the right side, as we can see here, for those who receive obrigipad first and then after that they have obrigipad, they reach to almost 55% relief, pain relief in comparison to the other group. So this slide is about the early treatment. They found that 22 hours pain freedom with obrigipad was achieved quicker and faster, and those receive the obrigipad earlier in the phase of migraine in comparison to those receive it late. And this goes with the pathophysiology. So we are blocking the peripheral sensitization before the central sensitization occur, and that's why the pain is relieved more and more. Moving to the last part of my presentation in the last 5 minutes. So here we are talking about the atogepant, which is once daily gepant blocking the CGRP receptors, and it is mainly used for as a preventive treatment in episodic and chronic migraine. And the half-life is almost 11 hours, and the metabolism through the CYP3A4 mechanism with less side effect on the liver. So an important point here, whenever this medication is taken with CYP3A4 inhibitor, the dose should be less. If he was giving another inducer, CYP3A4 inducer, we need to increase the dose to 60 milligram. So atogepant clinical development program. So we have here two pivotal clinical trials and additional clinical trials, and they have more than one trials. Some of them is related to the episodic migraine like ADVANCE and long-term safety trial, and some of them is related to chronic migraine like PROGRESS and long-term safety. So as we can see here in the ADVANCE is mostly about assessing the episodic effect of atogepant in episodic migraine. It has 3 phases, 4 weeks, then after that phase 2 in 12 weeks, which was the randomization phase, and follow up at 2 weeks, 4 weeks, 5 weeks, 8 weeks, and 12 weeks to divide the patient to four groups, those receiving atogepant 60, 30 milligram, 10 milligram, and placebo. And then after week 12, there was a follow-up for 4 weeks. So they just assess that by migraine, monthly migraine days. So the patient almost who received atogepant 60% has almost less 4 days less of migraine per month in comparison to atogepant 10 milligram in comparison to placebo. So the most powerful dose was atogepant 60 milligram. And the second endpoint for the ADVANCE study was more than 50% reduction in 3-month average of monthly migraine days. And this was higher and achieved more and more by those group who use atogepant 60 milligram in comparison to atogepant 10 milligram in comparison to placebo. The side effect is almost comparable between the group, little bit higher in atogepant 60 milligram, but it was well tolerated by the patient. Phase 3 PROGRESS trial, it's what to evaluate the efficacy, safety, and tolerability of atogepant for preventive treatment of chronic migraine. So the primary endpoint would change from baseline in mean monthly migraine days across a 12-week, and this was achieved more with atogepant compared to placebo. And the second endpoint was a more than 50% responder rate in 3-month average of monthly migraine days. It was achieved more with atogepant in comparison to placebo. The side effect was almost comparable between the two groups. And the last slide or last 2 slides here is about the long-term safety trial. And also we have 3 phases for the screening period. And the randomization period was for the first 4 weeks, then followed by 52 weeks, where the patient is followed from week 2 until week 4 until week 52 through almost 15 visits. They divided the patient to 2 groups, atogepant 60 milligram and those who received the standard of care. And finally, the third phase was for follow-up. And the main side effect was constipation, which was more common in atogepant group with 7.2% versus 3% with placebo. Other side effect was almost comparable. And this is my last slide, which I like it really because it shows the atogepant, which provide migraine freedom in about half of all participants within 1 year. Let us concentrate only on the green bars. So the green bars show the 1 year, which is 52 weeks. So those who had 100% respond to atogepant, that means they have 100% migraine freedom, they reach almost 50%. Those who have 70% respond, almost reaching to 70%, and those who have migraine freedom after 1 year with almost 50%, almost we are talking about 84% of the participant who achieve 50%. So 50% of the participant after 1 year. That's why we need to give it a long term. This medication is, we're not talking about medication that is taken as needed. We're not talking about medication that is taken for 3 months or 4 months and after that stop it. It should be a long term, because as we know from the pathophysiology, migraine headache is a chronic condition that can reoccur from time to time. That's why putting the patient on this medication for long-term period, okay, will give the maximum benefit. As we can see here, almost 50%, almost 50% reach to 100% respond after using atogepant. What about combining atogepant with other gepant? Yes, we can combine it, and but with caution, and we need to monitor, of course, our patient for that. Close follow-up for migraine patient is very important, and having a daily diary for the migraine attack, another important point for our patient. So this was my last slide. It was a long, detailed presentation, but I hope it was informative for you, and inshallah, I'm waiting for your question. Thank you so much.
Thank you so much, Dr. Badr, for this illustrated presentations, which we went in fact in all the details, covering the approach for patients with migraine, highlighting this, the high-risk populations and the role of the family physicians, and then you landed in with aprogepant, the efficacy, the safety, and the durability as well. So thank you so much. Now we'll move, ladies and gentlemen, to another format of the presentation, just to cover the whole subject from different perspective. So here we have Dr. Gary Shapiro. He's an internationally recognized headache specialist and the medical director of Shapiro Headache and Pain Treatment Center in Canada. He's also a lecturer in the Department of Family and Community Medicine at the University of Toronto. Dr. Shapiro is a Canadian board certified in family medicine and diplomat of American Academy of Pain Management, and he has extensive expertise in headache disorders, migraine therapies, and pain management, with a strong focus on advancing evidence-based migraine treatment pathway and the physician education internationally. So we would like to welcome Dr. Shapiro for being with us here today, and thank you for accepting our invitation. Looking forward to learn more about more details about the treatment pathway of migraine. So the floor is yours. Go ahead.
Salam alaikum, and thank you very much, Dr. Ashraf and Dr. Badr bin Hamid, for those excellent presentations. My presentation today will be a case-based presentation where I hope to be able to walk you through a case and illustrate some of the unique features and some of the clinical features and advantages of some of the newer medications that we're using for migraine treatment, both for the abortive and the preventative treatment of migraines. This session is funded by AbbVie. These are the disclaimers. The content of this presentation is intended for medical education and not for the promotion of any product, and is based on evidence-based medicine. In the event of any comments on the materials presented, please contact the Saudi Food and Drug Authorities on the unified number 19999. These are my disclosures. And what I hope to be able to talk about today is the learning objectives will be, to review, because Dr. Ashraf and Dr. Badr bin Hamid did an excellent job on defining the diagnostic criteria for episodic and chronic migraine, describe available migraine prevention and acute migraine therapies, including CGRP blockade as a novel approach, and apply practical strategies on the use of migraine prevention and acute migraine therapies in the primary care setting. And I'll be doing this through a case-based approach as we move forward. I do want to say that I am a family physician, and I've been trained initially as a family physician before I became a headache consultant. And I do think that, as Dr. Ashraf had said, migraine patients present to the family physician first. And there's so much that we can do with these patients. There's a lot of unmet needs, and the newer medications are very effective and well tolerated. And I think there's you can really move the needle quite a lot when it comes to increasing the quality of life of individuals if you get the proper diagnosis and treatment. So enough of that. We're going to talk about the classification of headaches. As we know, headaches are broken down into two very large groups. Primary headaches, by definition, no underlying medical cause, migraine, tension, cluster headaches. And then secondary headaches that by definition are related to an underlying medical cause. Vascular, non-vascular tumors, aneurysms, head and neck injury by definition is a secondary headache. And that's one of our first things that we need to do as family physicians when a headache patient presents to the office is determine, is this a primary headache or is this a secondary headache that requires interventions with more extensive investigations and then likely some referrals to our neurology or neurosurgical colleagues. But the vast majority of patients who actually present to the primary care office suffer from migraine headaches. And as we've heard from Dr. Badr bin Hamid, the way you make the diagnosis of migraine is to have at least two of the following qualities: unilateral, pulsatile, moderate severe pain intensity and aggravated by or causing avoidance of routine physical activity. So you only need to have two of those, and at least one of the following: nausea and or vomiting, photophobia and phonophobia, and not better counted by another ICHD3 diagnosis. So 2 + 1 = migraine headaches. And I think it's because of this large combination and permutation of symptoms that often the migraine diagnosis gets missed, because you can have, by definition, a bilateral pressure headache that has no nausea or vomiting, but some sensitivity to lights and photophobia and some phonophobia and phonophobia that is a migraine just as much as, you know, the unilateral throbbing headache associated with nausea and vomiting. And I was presented by the Migraine First Stop. This is an educational pamphlet and brochure made by the Saudi the Saudi group that really encapsulates a lot of the things that we need to go through when we make the diagnosis of migraine headaches. Number one, within this first stop, there's looking at the SNOOP algorithm to rule out secondary headaches. So if there's any systemic symptoms or signs, neurological symptoms, sudden onset of headaches, if the headaches are presented in an older individual, if there's a progression of headache pattern, if there's papilledema, a positional aggravation, or precipitation by Valsalva. If yes, then we need to investigate and concern ourselves by with secondary headaches. If not, then we go ahead and make our diagnosis. And again, within the first stop, you have the diagnostic criteria, which I laid out earlier on, and which Dr. Badr bin Hamid had discussed as well. You have to have 5 headaches with, you know, the following criteria. And then we, within the first stop, it also discusses the phases of migraine through prodrome, aura, headache, and postdrome. And we're paying a lot of attention to prodrome right now because it really sort of puts together the continuum of headache. And whenever we discuss prodrome with our patients, our patients are all, oh yes, I get that. I get a sore neck. I get tired. I get sensitive to lights before a migraine happens. Not everyone has a migraine, has an aura, but certainly they obviously have the headache and the prodrome, postdrome symptoms. And then finally, within the migraine first stop, there's the three question ID migraine PIN questionnaire that Dr. Badr bin Hamid had discussed as well, where you ask our patients, you know, because of that combination and permutation of symptoms, the diagnosis sometimes can get skewed. So do you have photophobia with your headaches? Do you have impairment? Does your headache prevent you from doing things when you have a headache or inhibit your ability to do activities? And do you have any nausea or upset stomach? And if you answer 2 to those 3 questions, then there's a very strong likelihood that you are suffering from migraine headaches. And these are the references for that First Stop migraine educational brochure. And migraine is a continuum. Not everyone sort of wakes up and has, episodic or chronic migraine headaches. Very often there's a continuum where individuals have episodic low frequency migraine headaches that are defined as between 1 to 6 days per month. And then that can transform to what we call high frequency episodic migraine headaches, those individuals who suffer from headaches between 7 and 14 days per month. And that can further transform to chronic migraine headaches with a high disability, where individuals have headaches between 15 and 30 days per month. And over a lifetime, a person can experience attacks that vary in frequency and severity based on a variety of factors, including our medical management, but also seasonality and the natural variability of migraine headaches, pregnancy, postpartum, perimenopause, postmenopause, menarche. A whole host of factors can trigger off and aggravate and help settle down the frequency of migraine headaches, along with our medical management. So now I'm going to discuss a case which I hope will help to illustrate some of the hurdles that we have when treating some of our patients who have migraine headaches. This is Grace. She's a 27-year-old woman. She's had a history of headaches for 10 years. Her headaches average between 4 to 6 headache days per month. So she's in the upper range of the low frequency episodic migraine. She has holocranial headaches. They're bilateral. They're throbbing. She has no nausea or vomiting. She does have some sensitivity to lights and noises, and they are aggravated by physical activity. So based on the IHD criteria, based on the 3-questionnaire PIN diagnosis questionnaire, she absolutely has migraine headaches. There's no red flags. Her history and physical examination is normal. She gets a diagnosis of episodic migraine headaches. She's treated her headaches with ibuprofen or acetaminophen, which was ineffective. They just did not work. She was prescribed sumatriptan and then almotriptan. Both of them she found effective, but they made her feel terrible. And although they helped with her headaches, she felt so bad from the side effects that she didn't bother taking them. And she comes to you looking for help with her pain relief. So what other options exist for Grace for the abortive treatment of her migraine headaches? We've heard a lot about the GPANT medications, but let's just take a review of some of the medications that are often used for the abortive treatment. Anti-inflammatories, over-the-counter anti-inflammatories, and acetaminophen, in Grace's case, didn't work. Usually not sufficient to control migraine attacks. Patients often take them irrespective. Caffeine is often used as an augmenting treatment and can be found in a lot of combination analgesics that have a combination of caffeine, acetaminophen, and sometimes even some low-dose codeine and opioids. DHE, which is not very often used, certainly not in Canada anymore. There are some patient devices, cooling devices, the Cephally that was mentioned earlier, heating devices, glasses, earplugs, menthol topical treatments. Opioids to be used as a last resort. There's certainly concerns of risk of addiction and risk of medication overuse, and cannabinoids. And in Canada, cannabinoids are frequently requested and asked with respect to the abortive treatment of migraine headaches. And the evidence is really very lacking with respect to that. And there are potential concerns about medication overuse, but it's certainly in the landscape of treatment options. And then we have the triptans, which have been around for many years: sumatriptan, zomatriptan, rizatriptan, almotriptan, elatriptan, naratriptan, frogatriptan, all effective, generally well tolerated, generally effective, but there are a lot of gaps in the treatment because they do have side effects. They do have cardiovascular contraindications. They do have tolerability issues, and they're not universally effective in any group of individuals. And if you look at the triptan, the efficacy data, and this is compiled, this is based on a meta-analysis. These you can't really compare head to head. But for the most part, these medications are far more similar than they are different. They differ a little bit with respect to delivery systems. Zomatriptan has a nasal spray. Sumatriptan has a subcutaneous injection. But you know, the pain relief data is typically in the low 60s. Pain-free data in the 30-35%, and sustained pain-free between 40 and 50%, depending on the clinical trial. So effective, but there certainly are some unmet needs because of lack of efficacy, because of risk of medication overuse, because of side effects, tolerability, safety in patients with cardiovascular risk factors. There's an excessive use of opioids and barbiturates, and in Canada, that's been a huge problem over the years, and preventing migraine disease progression. So we want to be able to find a medication that is effective, safe, well tolerated, and does not cause medication overuse. And we have been, over the last few years, fortunate to be having the GPANT medications, which is the first class of medications that have sort of broken down that wall between abortive and preventative medications, because they can be used for both the acute abortive treatment of migraines as well as the preventative treatment of migraine headaches. We're going to start off talking a little bit about the acute migraine medications, and there are two of them available in Canada: rimegepant and ubrogepant. Ubrogepant for the acute treatment of migraine headaches. It's a CGRP receptor antagonist. It's an oral tablet. And then rimegepant for both the acute and episodic migraine preventative treatment, because that medication can be used for both. And it's a CGRP receptor antagonist, and it's an oral tablet. And so, Dr. Badr bin Hamid had done an excellent job of describing some of the clinical trial data with respect to the GPAN. So I'm not going to go and repeat that, but I do want to, sort of maybe make a comparison is, how do the GPANs compare to the triptan medications, and where do they fit within the landscape? Because we do know that there are cardiovascular contraindications. We do know that they have some tolerability issues, and we do know that they can cause medication overuse. But how are they with respect to efficacy and tolerability? And what about patient preference? Unfortunately, there are no head-to-head clinical trials with a GPAN and a triptan. Maybe that will happen one day. I don't think it will. So there is an open label Universe 2 study design, which sort of tries to compare ubrogepant and a new triptan medication. And the objective was to evaluate real-world effectiveness of ubrogepant versus a triptan in terms of patient-relevant outcomes, which study aims to describe as work productivity, migraine disability, satisfaction, and treatment experiences among people who have switched to ubrogepant or a new triptan medication. The inclusion criteria were individuals who switched from an oral triptan used to treat at least 2 headache attacks to a new oral medication or ubrogepant in the last week. They had to be over 18, experienced headaches in the last 6 headaches in the last 90 days, and access to enough pills to treat migraine headaches. So they treated at least 2 attacks with a triptan. They were divided into an ubrogepant and then a new triptan group. They had a screening at baseline and then a primary assessment at 4 weeks. And what they found was the satisfaction with ubrogepant or a new triptan was that participants who were put in the group switched to ubrogepant had a 3.2 times higher odds of being satisfied with treating the pain associated with migraine, and a 3.1 times higher odds of being satisfied with alleviating the most bothersome symptom than those who switch to another triptan from a prior triptan. So certainly these medications are effective in individuals who have either not tolerated or not found a triptan to be effective. And overall preference for treatment and likely to continue on with the new treatment, ubrogepant was significantly statistically superior to that of the new triptan medication. And participants who switched to ubrogepant had a 1.3 times higher odds of better complete migraine relief at 2 hours with the new treatment versus the previous treatment than those who switched to another triptan from a prior treatment. So certainly these medications can be used in individuals who have either failed to respond to triptans or who have failed based on tolerability issues. So let's get back to our caseworker, Grace. So she was looking for an abortive medication that was going to hopefully help her when she had a migraine attack. You prescribed ubrogepant 100 milligrams for her. And she said, you know what, this was really well tolerated. I didn't have any problems with side effects. You know, maybe it worked a little bit slower than her triptan in the past. Maybe it wasn't quite as quick. What advice would you give her at this point in time? We've known for a long time that most migraine medications, whether it's a non-specific oral medication such as acetaminophen or ibuprofen or diclofenac or naproxen, or whether it is a triptan, works better when you take it early into the headache. And we've always stressed, take our medications early into the headaches. People delay for a variety of reasons. But, you know, we've often been speaking out of both sides of our mouth as clinicians because we've said, treat early, treat early, treat early, but don't treat too often because you're going to get medication overuse. So we're giving a bit of mixed messages to our patients. And similar can be said for the gepant medications. If you treat early, and this is a post hoc analysis of mild versus moderate to severe pain, that individuals who treat early with ubrogepant find that their headaches improve better than if they waited till their headaches were moderate to severe. So the natural advice is to take the medications early into the headache. And then there was another study called the prodrome study, which took it one step further, which was, let's say, maybe we can treat even before the headache starts, because we can identify what our prodromal symptoms are, and we're less concerned about advising our patients to take early, and take during the prodromal period, because we're far less concerned about the gepants causing medication overuse, because we know that they can, if taken on a near daily basis, sort of morph into a preventative treatment. So the prodrome trial was a multi-centered, randomized, double-blind, placebo-controlled crossover trial that assessed the efficacy and tolerability of ubrogepant when administered during the prodromal symptoms. And the most common prodromal symptoms were the following: sensitivity to light, fatigue, neck pain, sensitivity to sound, and dizziness. And when I'm counseling my patients, I'm saying, okay, now, you're on a gepant medication. You can take this during the prodromal symptoms. They go, well, what's prodrome? And we describe to them, well, sensitivity to light. And they go, yeah, I got that. Fatigue, yeah, I got that. Neck pain, yeah, my neck always starts to hurt before a migraine. So we can start counseling our patients to say, well, maybe we should take the medication prior to the headache starts during the prodromal period. And this prodromal study actually proves that out, with the primary endpoint, absence of moderate or severe headaches, significantly higher than placebo, and higher than the efficacy rates that we typically see in a lot of the abortive therapies. So absence of moderate to severe headache within 48 hours, and absence of headache or any intensity within 48 hours when taken during the prodromal symptoms. So Grace comes to you and you say to her, okay, well, you advise her to take Obrogepant very early into her headache, and you educate her on the prodromal symptoms. She goes, yeah, you know what? I do get neck pain, and I do get sensitive to light, and I know I'm just off. I don't have a headache yet, but I'm off. And she finds when she does it, the Ubrogepant works far faster and is more consistent. But her headache frequency is now increased to 8 to 10 days per month. And she's taking Ubrogepant at least 2 to 3 times per week. And she remembers when you advised her about medication overuse with triptans and anti-inflammatories, and she's concerned that maybe I'm taking the Ubrogepant too frequently. Is this a problem? And you advise her, and she asks you, what do I do? And then she says, is there anything else I could do? Maybe what about preventative therapies? So Ubrogepant and medication overuse. Ubrogepant does not induce latent sensitization in preclinical models of medication overuse headaches. And the study suggests that Ubrogepant may offer an effective acute treatment of migraine without the risk of medication overuse. And clinical studies are warranted to confirm this finding and whether it applies across the attack. So if individuals are taking GPANT medications on a very frequent basis, it can morph into a quite possible prophylactic effect. So I'm far more comfortable telling my patients who are on GPANT medications to take early into the headache, take prodromally, and not be as concerned about medication overuse, because clinically we just don't see it happening, and the pathophysiology certainly warrants that. So then the question is, does Grace require preventative therapy? She's suffering from headaches now 8 to 10 days per month. What is the threshold for prescribing preventative medications? The Canadian Headache Society recently reviewed some 2024 guidelines, and the goal really is to try to prevent the transformation from individuals who have, high frequency episodic migraines or low frequency in the 4 to 6 days per month, to transforming into high frequency and chronic migraine headaches by using preventative therapies. A prophylactic medication is usually considered effective if migraine attack frequency or intensity is reduced by 50% or more, and lesser reductions in migraine frequency, such as 30%, are generally considered to be significant in individuals with chronic migraine. So the expectation really should be in episodic migraine, 50% reduction, in chronic migraine, anywhere between 30 and 50% reduction. And the threshold really in my practices now is anywhere in, typically, if someone's presenting with 4 to 6 migraines per month, depending on how well their abortive therapies are, that's when we start talking about preventative strategies. And reduction in headache intensity and migraine-related disability also need to be considered when judging the effectiveness of preventative therapies. Keeping a headache diary is always recommended to evaluate the effectiveness of preventative therapies, but we often use this global impression of change, overall in general, adding it all up, are your headaches same, better, worse? And if they are better, how much better are they? Better by 10, 20, 30, 40, 50%. Many individuals we counsel them to keep a headache diary, but unfortunately, life is busy and they often fail to do so. So these are the current 2024 CHS guidelines, first-time strategies for migraine prevention. And they broke it down into episodic migraine headache and chronic migraine headache. So episodic migraine headaches, the strategies are metoprolol, nadolol, propanolol, candesartan, and amitriptyline. All have strong evidence with high quality, strong recommendations with high quality of evidence. And for chronic migraine, beta blockers such as propanolol, CGRP blocking monoclonal antibodies also for high frequency episodic migraine headaches with moderate disability. So these medications, the monoclonal antibodies and the GPANT medications prevention, are also indicated for individuals who have episodic migraine with moderate disability. And then, of course, onabotulinum toxin A. All of these have strong evidence with moderate to high level quality of evidence. Selection of preventative medications is often made based on how efficacious they are, the side effect profile, comorbid disorders, patient disability, migraine severity, pregnancy planning, and appropriate contraception. In Canada, before we can access the CGRP blocking medications or even Botox, patients have to fail at least one or two non-specific oral preventive medications, such as beta blockers, candesartan, or amitriptyline. And the way we often prescribe these medications is we use the side effects of the medication to sort of work in a manner that the side effects may help the individual. So if they have comorbid fibromyalgia, and they don't sleep well, amitriptyline may be a good choice. If they have comorbid depression, amitriptyline may be a good choice. If they have comorbid hypertension, then either a beta blocker or candesartan could be. And when we look at the efficacy rates of the CGRP monoclonal antibodies, similar to the triptans, these are separate trials. These are not really comparable to one another, but typically these medications far more similar than they are different, with efficacy rates in the episodic migraine headaches in the 50% ballpark, and for chronic migraine between 30 and 40%. Very effective medications. But there still are some unmet needs in migraine prevention. They're not effective enough. Sometimes they are too many side effects, slow to get started. They do not treat the cause. There's underuse of current treatments, fear of preventive medications, and the preference for natural options such as vitamin B2, magnesium, coenzyme Q10, underestimation of burden, and need for better and specific treatments. So let's get back to Grace now. She's now 31 years old. She's a long-standing history of episodic migraine headaches that had transformed to high-frequency episodic migraine headaches. You tried her on amitriptyline. It was ineffective, and she was overly sedated. She did not like how she was feeling. You tried her on candesartan. It was not effective. You were hesitant to push the dosage because she was borderline hypotensive. So you started her on a CGRP blocking monoclonal antibody. And she found, after several months, before noticing that it took several months before she noticed an effect, but it was effective for her. But she had to stop the monoclonal antibody 6 months before deciding to get pregnant. And this, aggravated her headaches before she got pregnant. So we have the GPANTs as a prophylactic treatments for migraine. And we have 2 GPANTs available in Canada and in the United States. We have atogepant, which is approved in Canada and the United States for both the episodic and preventative treatment of episodic and chronic migraine headaches, and similar to that of the monoclonal antibodies, and CGRP receptor agonist, and it's an oral tablet. And then you have rimegepant, which is for both the acute treatment of migraine headaches and the preventative treatment of episodic migraine headaches only, and not chronic migraine headaches. There's no indication for that. In Canada, we don't use rimegepant as a prophylactic treatment. It's only used as an acute treatment for migraine. It's the only indication that we have, and it's an oral disintegrating tablet. So similar to when we talked about the triptans versus the GPANs, Dr. Badr bin Hamid had done an excellent job of describing the clinical trial data for atogepant, and I'm not going to repeat that, but I do want to present some data about how does atogepant compare to non-specific oral preventative medications, such as Topamax. And here's the Temple trial, which is a randomized, placebo-controlled, a randomized placebo-controlled trial looking at the tolerability, safety, and efficacy of atogepant. This is happening all by itself, not by me, but I'm going to try to keep you here just to give you a little bit of the clinical trial scheme. But essentially, it is a clinical trial that is comparing double-blind comparative trial between atogepant and topiramate, which is a very effective migraine preventative medication. This is, however, it does have a lot of tolerability issues, and this clinical trial is quite relevant in what we see in our clinical experience, in that it showed that treatment discontinuation due to adverse events across a 24-week double-blind period was close to 30% with topiramate and at 12% for atogepant. So clearly atogepant is a much better tolerated medication. And then you look at the actual mean monthly days and the efficacy of this medication, that it is both superior in terms of efficacy and quite dramatically superior with respect to tolerability. So certainly atogepant versus topiramate, in my mind, that's a no-brainer, far more effective, far better tolerated, and without some of the complications of topiramate. And how does atogepant compare to the monoclonal antibodies? Another important factor, because we often have the option, do we prescribe a gepant medication or do we prescribe a monoclonal antibody medication to our patients who are indicated for CGRP blocking medications? And there are advantages and disadvantages to both of them. I think really with respect to how do you compare them, monoclonal antibodies are obviously injections, and the gepant is a pill. And the advantage of that is that it has a short half-life. So if someone is planning on getting pregnant within the next 6 months or so, I think a gepant may be a more appropriate medication, because patients have to stop monoclonal antibodies because they're very long half-life, typically 5 to 6 months before they even consider getting pregnant. The monoclonal antibodies are injected every month or every 3 months, depending on the monoclonal antibody, whereas gepants are a pill. And there's a comfort level with prescribing pills by family physicians, and I think by taking them as patients. They're both indicated for the preventative treatment of migraine headaches, acute and preventative for the gepant medications. The monoclonal antibodies can either target the CGRP ligand, such as galcanezumab, fremanezumab, and eptinezumab, or its receptor, such as erunumab, whereas the gepants work similar to erunumab in that they target the CGRP receptor. And there is the monoclonal antibodies, there's no interaction with oral medications, and with the gepants, there's interactions with CYP3A4 medications. The common ones that we use in clinical practice would be clarithromycin, an antibiotic, and verapamil, which is antihypertensive medication. But on an efficacy level, these medications are very similar with respect to their clinical trial data, where they show in and around 50% responder rates in episodic migraine headaches, similar to that of the gepant medications. So effective medications, it's really, about tolerability, it's about, the individual lifestyle and the half-life and the biomechanics of the medications. Another advantage of atogepant is its onset of action. because it's a GPANT, it can start working within 1 day of, and this is, time course of efficacy within the advanced trial results. So one advantage of atogepant is that it can start working very quickly and compared to some of the monoclonal antibody medications, one difference. There is one trial, which is a benefit risk assessment of atogepant versus CGRP monoclonal antibodies. This is a meta-analysis. It's not a clinical trial in itself. It's an evaluation of the clinical trial data from a whole host of different clinical trials and a statistical analysis. And the objective was to evaluate the benefit risk assessment of atogepant and CGRP blocking monoclonal antibodies versus placebo based on the numbers needed to treat and the numbers needed to harm. So the efficacy and the side effects in the blended episodic and chronic migraine population. And atogepant demonstrated the lowest number needed to treat compared to CGRP monoclonal antibodies. So it means that the most efficacious in that you need to treat the fewest number of patients to get a positive result. And correspondingly, it also had the lowest number needed to harm with respect to tolerability and side effects within this meta-analysis. So atogepant can be a very effective, well-tolerated medication in comparison to the CGRP monoclonal antibodies. The benefit risk assessment of atogepant versus MABs study limitations because this is a meta-analysis. The treatment period was limited to 12 weeks, preventing the evaluation of long-term efficacy and safety. Based on the heterogeneity measures, there was no significant superior fit for random effects models relative to fixed random effect model, suggesting that the treatment effects across episodic and chronic migraine are comparable. However, the blended episodic and chronic migraine analysis does introduce differences in the study, and there may be potential differences in treatment effectiveness across episodic and chronic migraine patient populations. So let's get back to Grace. During her, she gets pregnant. She had to stop her a monoclonal anti, and she had twin boys, and her headaches increased after having twins. Now she has headaches anywhere between 10 and 20 days per month. She's currently not nursing, but she may want to get pregnant again in the next year or so. She's treating abortively only with ubrogepant. You discuss her options on Botox injections, but there's a 6 to 12 month waiting list for her to get to see a neurologist or a headache specialist. She had experience with CGRP monoclonal antibodies. She doesn't like taking needles, and she's not using any birth control pill or an IUD. She's using only barrier methods, and she found it slow to act. So she was enrolled into the patient support program and prescribed atogepant. She found that it was very effective and well tolerated. Her migraine headaches are now down to 3 per month, and she's very happy. But she likes her ubrogepant. She doesn't want to have to go back to her triptan medication. She wants to know if she can still use ubrogepant while she's, as an abortive medication, while she's taking atogepant. So there is a safety and tolerability of ubrogepant for acute migraines in participants taking atogepant for preventative treatment study called the TANDEM study. And it's a screening period where individuals who are on open label atogepant, a treatment period, they take open label atogepant and then they're given ubrogepant as an abortive therapy, and there's a safety and follow-up. And what they found was, number one, that individuals who were taking atogepant for prevention found efficacy with ubrogepant when they used it for an abortive agent, and quite high levels of efficacy. Granted, this is an open label study. This is not a randomized placebo-controlled trial, so the numbers are obviously a little bit higher. But pain freedom and pain relief at 2 hours and sustained pain freedom and pain relief at 2 to 24 hours are consistently exceeding 50% for breakthrough migraine attacks in individuals who were using ibrogepant and treating during that second period of treatment. And then they looked at the treatment emergent adverse events, and they were pretty much similar to what we typically see with atogepant as a preventative medication and ibrogepant as an abortive therapy. Maybe some fatigue, maybe some nausea, maybe a little bit of decreased appetite and constipation. So nothing significant more with tolerability issues. And the treatment adverse events, depending on the days that they used ibrogepant, were anywhere between, if low use, moderate, or high use, were again the similar side effects that we see with both these medications. Some nausea, some decreased appetite, some constipation. So it is effective, and it is safe to use ibrogepant as an abortive agent when atogepant is being used as a preventative therapy. So I'd like to just conclude with a couple pearls of wisdom for migraine management from a clinical perspective. Some practical tips and key points. It's important to address both safety and tolerability profiles when discussing migraine preventative options with patients. Side effects are also depend on medical comorbidities such as liver kidney disease and potential drug-drug interactions. The CGRP monoclonal antibodies and gepants are well studied, and while they have some reported side effects, mainly constipation, maybe some nausea, they're generally very well tolerated, and certainly better tolerated than the majority of the non-specific oral preventative medications. And discussion with female patients of childbearing age can include the lack of safety data available during pregnancy, family planning, and consideration of agents with a shorter half-life to provide flexibility. Preventative therapies are important components of preventative therapies. There's some new therapies such as monoclonal antibody and gepants for both abortive and preventative treatments. And these new options are important additions to the treatment landscape with the ultimate goal of improving patient outcomes. In Canada, we have several resources to empower patients. We have a library of PDFs of migraine basics. There's some podcasts. There's some excellent webinars. And there's a Canadian migraine tracker, similar to the headache diary that Dr. Badr bin Hamid had discussed about. This is the Canadian migraine tracker. Comes in it's an app. It's on Android and Apple iOS, and all of our patients use it. They try to use it. We suggest that they use it. They don't always use it. And the Canadian Headache Society has a large reservoir of self-learning programs that can be seen under these URLs. And this is, again, just another plug for the Canadian Migraine Tracker. Very effective tool to help with the monitoring of symptoms and the days of treatment for migraine for our migraine patients. So I'd like to thank you very much, and we, I think, have a few minutes for some questions.
Yes, thank you so much, Dr. Shapiro, for this wonderful presentation. It's almost what you have contributed to you and Dr. Badr bin Hamid. It's almost like a master class, which was delivered to the audience today. And I think that they have, by the time they should master all the features of diagnosis, management, and the pearls that you have presented finally was quite interesting. So in fact, most of the questions which I received has been answered during the presentation, so we don't want to go through it, but I have some of the questions will be focused on the CGRPs and ibrogepant. Dr. Badr, which patient benefits most from CGRP targeted therapy? What is the profile of patients from the clinical point of view as you sit in your clinic? Which patient you will say, this is the patient where I'm going to start the CGRP? Is it after going through the different modalities, then NSAIDs, triptan, and then CGRP, or there is a special group of patients whom you can, select the CGRPs to be the first line?
Thank you, Dr. Ashraf, for this question. So from practice, We have different type of patients really that can be seen in family medicine practice. So we are seeing elderly patient, we're seeing adult, we're seeing even young patient coming for the first time with undiagnosed. So sometimes most of the patient, those who have frequent episodic migraine, really this is the mostly benefited, really benefit from CGRP treatment, whether the preventive and the acute management. Sometimes they are naive patients. They didn't use anything before more than other than non-steroidal paracetamol. So whenever you discuss the migraine, explain the pathophysiology, explain the criteria simply, and once you have the diagnosis, the patient will be convinced. So this is one profile. Second profile, we have almost this is a little bit elderly patient. They are 50 or 60, used many modality, even non-pharmacological treatment, and they are coming to you, by the way, after visiting even many neurologists. So they are asking for is there any new modality of treatment? But this is the second profile of patient really who benefited well from CGRP, whether acute or chronic.
Excellent. Well said, Dr. Badr. In my clinic, I usually tend to use it after the failure of triptans, or if triptan is contraindicated, especially for patients with a cardiovascular disease. So CGRP with a special focus on epinephrine will be the choice. Dr. Shapiro, how should the clinician or the primary care physician or a family physician, as we are today, balance efficiency, safety, and cost when selecting a newer migraine treatment when it comes to CGRP?
Yeah, well, with the efficacy, I sort of break them down into abortive therapies and preventative therapies. So with abortive therapies, I often suggest a non-specific oral therapy such as ibuprofen or acetaminophen, that they can use it sometimes. They're very cost effective, but obviously not always effective. But I'm going more to the GPANs, sometimes even bypassing the triptans because of the safety and the tolerability and the efficacy of these medications. And preventatively, in Canada, we're really sort of forced to try at least 2 non-specific oral preventative medications. But after that, provided that individuals have insurance, we go directly to the monoclonal antibodies or the GPAN medications, depending on a whole host of factors, patient preference after having a discussion with them.
Well said. In fact, here we have some kind of limitations regarding the approval by the insurance company.
Yes.
Sometimes they mandated us to go stepwise, till we reach the failure of the treatment to start GPAN. But I think we did not reach to the mindset that we have to work through the patient need and the clinical feature of those people that need the GPAN as a first-line management. Do you think, Dr. Shapiro, that there is any specific migraine phenotype that responds better to personalized treatment approach? Because there is some kind of variabilities in the response.
Yeah, I think that's an excellent question, and that's very nuanced. Because it would be lovely to be able to sort of say, well, this individual who has very a lot of nausea and a lot of sensitivity to light would do better to this medication, and this individual who does not have those symptoms would do better. We don't have any clinical trial data to discuss what medication would work better based on the headache phenotype. I would say, though, if someone has a very abrupt onset of headache, maybe a triptan would be more effective because of the speed of onset. If people have comorbid fibromyalgia, they're very sensitive to medication, they have a lot of side effects, a GPAN would be more effective as an abortive agent. And then when we get to prophylactic therapies, I look at the comorbidities of the individuals, depending on how I'm going to prescribe our medication. So if they have comorbid hypertension, then absolutely we would prescribe a beta blocker or candesartan as a first-line preventative therapy before we went to a GPANT or a monoclonal antibody. But I think, you know, it's an excellent point, and I wish we could be able to say, okay, well, based on these headache characteristics, this medication would work better. I think speed of onset, maybe something is a factor. Certainly significant nausea and vomiting where you may want to bypass the GI absorption with either a nasal spray or a subcutaneous injection with a triptan medication would be appropriate.
Okay, well said, Dr. Shapiro. Dr. Badr, as you are leading a department of family medicine, IMC, and alhamdulillah, mashallah, is going very well under your leadership. So if a question comes to you saying, what is the one major change primary care physicians should adapt immediately to improve the migraine care from your own clinical experience? What is the major change that a primary care physician should adapt immediately to improve the migraine care? Of course, we know that there is many pitfalls, many obstacles, and many unmet need. But what is your advice?
So 2 points. Number one, to believe in themselves as a competent and confident family physician. So always, I say to my colleague, to my resident, on all student coming to us, okay, as a family physician, you are competent and confident enough to deal with all diseases within a limit. So know your limit, number one, and your limit is based on your experience and expertise. The authority, once you have the authority in a place that give you the authority, that give you the empowerment, so you need to use this empowerment to the maximum. So I believe in most of the secondary and tertiary centers, and I believe and I hope that even primary center will have this. Once the physician, the family physician, believe them in themselves, okay, they will move from just reading the information and listening the information like what they are doing, what we are doing now, to practicing this information. Number two is breaking the ice. So sometimes we still have this taboo, like, okay, migraine is a condition that should be treated by a neurologist. No, we should break this. No, and even by our colleague neurologist, they are asking us, please start the treatment, initiate the treatment. So I believe believing in us and breaking this taboo and breaking this ice and start to use this new medication after all of this information, after knowing all of this hand-on, start practicing in managing migraine, hand-on in using these medication, following your patient. This is what will give you the experience, okay? Just referring the patient to a neurologist or to a pain clinic, you are losing really an excellent experience that really can move the management of migraine in primary care from just giving a paracetamol or non-steroidal to really to the maximum and advanced level in dealing with these cases.
Thank you so much, Dr. Badra. And I think nowadays we are witnessing a paradigm shift in the competency of family physicians, you know, in comparison to 20, 30 years ago. Nowadays, we are confident enough, we are empowered by our healthcare transformations based on primary care and putting the family physician as a champion for this kind of transformation. And we are witnessing also another level of performance in certain areas. For example, hyperlipidemia. Now we are using the injectables in chronic kidney disease. We did a remarkable improvement. So our family physician, they can manage stage 1, stage 2, stage 3A with full confidence. So we have divided the pie equally between primary care physician and the nephrologist. So I think this is where we have to put our confidence in ourselves and to move ahead with migraine the same we did with others. Okay, Dr. Shapiro, at what threshold do you start preventive migraine therapy in the real world practice? When you say you would like to start at that particular moment when you are treating patients with acute episodic migraine?
Yeah, a good question. And I think really I start the conversation when individuals are suffering from headaches approximately 4 times per month. If they're having 4 to 6 per month, you know, it's obviously always up to the patient. We can give our advice and we can introduce the idea of preventive therapies Often patients are a little hesitant about that, but it's in and around 4 to 6 times per month that I would say, yes, I think this is something that would be appropriate.
And what is the safest migraine treatment during pregnancy and breastfeeding? You have mentioned it,
Yes,
but
well,
this is a question coming
yeah.
frequently repeated by the audience.
Yeah. Common things being common, women often get their migraines get much better in the second trimester and third trimester of pregnancy. But if you're going to treat them prophylactically, CGRP blocking medications are not approved. Metoprolol beta blockers is something that we often use, amitriptyline and sumatriptan, and along with, of course, acetaminophen.
Absolutely. There is a question for both of you. If you just can share your experience, where do you position Aprogepant in acute migraine algorithm in relation to other CGRPs and triptans and ditans? Where do you position it? Is it based on the profile of patients?
In Canada, for preventative treatment in Canada, we have to use 2 non-specific oral preventatives first. So I would love it to be first line therapy where I could but insurance companies and government sponsored insurance companies require a trial of either candesartan or a beta blocker. But after that, it's the first line in terms of what we discuss with our patients. We discuss, maybe we'll use monoclonal antibodies, discuss the advantages and disadvantages, and discuss the advantages and disadvantages of atogepant. But it's really initially right after our 2 non-specific oral therapies.
And there is any evidence, Dr. Shapiro, that Aprogepant reduced the progression of a chronic migraine by improving the early attack control?
Well, there's no specific longitudinal studies that I'm aware of that actually say that it prevents, but by treating it, you're certainly preventing it from occurring.
All right. So I think we're coming to the end of this scientific gathering. But before that, I would like to ask each one of you to say one single statement as an advice to empower and to encourage the primary care physician to take their actual promising role in the management of migraine.
Dr. Badr bin Hamid had said it beautifully just earlier on, and I would likewise in Canada and Saudi to empower family doctors to treat migraine, because it's a primary care condition, and it is a very, very gratifying condition to treat because the medications are effective and well tolerated, and our patients are highly appreciative when you can transform someone who has chronic migraine headache and completely disabled to someone who has very low frequency and has control of their life once again. And patients are very appreciative of that. And to have their life back is huge. So I would encourage you to just make the diagnosis and start treating.
Absolutely. Dr. Badr?
So I will start from the last point, really. Make the diagnosis, start the treatment, be confident, okay? Deal with migraine as a chronic disease like you are dealing with diabetes and hypertension. So whenever we deal with diabetes, hypertension, or cardiorenal metabolic, we go to the maximum. We read and we go to the advanced medication, and we are so comfortable. So please deal with migraine as a chronic disease like cardiorenal metabolic disease, and go to the maximum. And believe it or not, okay, even the upper management, even the main authority, they will support you, because I believe family medicine is always the first line. Thank you so much.
Thank you so much, Dr. Badr, and thank you for both of you for enriching our scientific event by your thoughts, your expertise. And I would like to deliver a message and to conclude by saying that migraine is quite common, very prevalent, and we have learned today who are at risk of getting into migraine, and what are the promising molecules like Aprogepant to manage patients with acute episodic migraine. And I don't want to say much, but I would like to end my talk by saying behind every migraine patient is a person hoping for relief and a better quality of life. And you, as a confident primary care physician, can make all the difference that is needed. So with this statement, ladies and gentlemen, I would like to thank you for being attentive to us. More than 850 participants today. They are witnessing this wonderful gathering. And I would like to thank ملتقى الخبرات لتنظيم المعارض والمؤتمرات. Thank you so much, Dr. Salma, on behalf of AbbVie, for being with us here today and supporting this wonderful scientific event. Looking forward, inshallah, to see you, ladies and gentlemen, again in other scientific event with a different competency, with a different capability of managing migraine, so we can go with our new scientific event higher up to more details. Thank you so much. Have a good night. It's to you, Dr. Salma, if you want to say something.
Thank you so much, Dr. Ashraf, Dr. Shapir, and Dr. Badr for this very informative session. Really, we learned a lot, and we hope that one day we can reach out to all migraine patients, empower primary care doctors, as you all said, to diagnose and to treat migraine.